disorders. Gallbladder, pancreas. So keep in mind, insulin self-explanatory. I think your glucagon is self-explanatory, but somatotestine, this one, just go with this one, right there. Inhibits the release of glucagon and insulin. It inhibits the release of glucagon and insulin. Just some pictures associated with where and all in relationship to the liver, the gallbladder, and then our pancreas. And then the spleen off to that other side. So when we're talking about pancreatitis, first and foremost, these are usually the patients that are in the ER waiting area and they're not eating Cheetos. They're the ones that are usually in a fetal position on the floor saying how much pain they are in mid-sternal. These are not the ones that are just saying, I'm having abdominal pain eating Cheetos or drinking some hot chocolate because it's cold outside. So, with that said, any bit of starting the digestive process can cause them more pain. So the number one thing we do for these patients is keep them NPO. This is not somebody that you'd be like, oh, you can have some ice chips because your mouth's dry. Because what that's going to do is start their GI process, or the digestive process. And the more the GI process starts, the more pain they will have, okay? So we want to not give them anything, so NPO for sure. So it just tells you definition-wise what it is. So it's an inflammation or infection in the pancreas. There's acute and there's chronic, okay? So acute, severe abdominal pain, again, mid-sternal, right in the middle. They could have ecchymosis in the flank or the umbilical cord area, and then chronic comes with fatty stools, weight loss, etc. So a lot of times, pancreatitis is associated with alcoholism as a whole. But you also have to think about those patients who do have, and aside from the alcohol, if it's somebody who has an inflammation in that pancreas, one thing we have to worry about is their blood sugar levels. So these people would be on sliding scales, which means that we have to check that blood sugar every 6 hours to see what that blood sugar is doing. Again, they are going to be NPO. We don't want anything to set off that digestive process. When it comes to assessment, keeping them NPO, learning their status, alcohol, medications, all that. An effective breathing pattern, because of where it's at, they're not going to be taking that deep breaths. They're not going to be breathing normally. Of course, impaired nutrition and impaired skin integrity also plays a role, especially if they have some liver dysfunction associated with it. So, when it comes to complications, all of this can be a complication of pancreatitis. But what we need to find out is what is the amylase and lipase doing with that pancreas? When the pancreas is inflamed or infected, amylase and lipase are the two pancreatic enzymes that will be elevated with pancreatitis. So of course we do our normal blood work, put them on monitor, etc., etc. Maybe nasogastric suction to relieve nausea and distension. We have to be careful with analgesics. So the one analgesic we have to be careful with is Dilaudid or hydromorphone. Any of the narcotics, let me just say, any of the narcotics can cause this to happen, a spasm in the sphincter of Oddi. You know anything about the pancreas? It has a sphincter of Oddi, ODDI. You may remember that. If you don't, look it up. Not right now, but look it up for future. Any narcotic opiate has that risk of causing spasms to that. If we cause spasm to the sphincter of Oddi, we're causing more pain for this patient. So the one that would be less likely to be given is hydromorphone or Dilaudid. Again, we could give another one like morphine, but again, it may relieve the pain, but it also could do the opposite. So all the narcotics have the risk of doing this. Morphine's less likely, but it could happen. So just so you know that in the back of your head. Don't be surprised as you're giving pain medication, the patient ends up getting worse. there's no way to work around it when it comes to narcotics. So amylase and lipase, NPO, these are patients that were resting the gut. So if they need nutritional support after that whole initiation of a 24 to 48 hours, and they're not relieved with the pain, and the enzymes are still increased, this would be somebody that we would do total parietal nutrition on. Along with, when you say the total parietal nutrition, or TPN, we also know that it's a sliding scale. Okay, so that goes hand in hand with that. But because their pancreas is inflamed and infection initially, we will also be doing every 6 hours sliding scales on these patients, checking that blood sugar. They can't even put a piece of whatever in their mouth. No, excuse me, their mouth is dry. Oh, here, let me give you a mint. No. Okay? Just, excuse me, cause them more pain. Oral care, frequent of course, but again, we don't want them to swallow or initiate anything. They should swish and spit, okay, with their oral care. And then pain, comfort as we can, and then of course relieving anxiety. So, last thing we're going to talk about is tumors of the pancreas. Pancreatic cysts, and then we have the cancer of the pancreas. Fourth popular, I don't know how else to say it right off the top of my head, but fourth popular in men, fifth popular in women. So fourth and fifth in the ranking. Rare before the age of 45. Risk factors: smoking, chronic diabetes, and pancreatitis are some of the risk factors associated. Smoking, the chronic diabetes, and that leads to the tumors of the pancreas. So different chemotherapies, radiation is limited. The reason why the radiation is limited is because where the pancreas is located. Lungs and heart are similar in that proximity, in that area. So that is why radiation is limited. Surgery. Treatment may be palliative, however, surgery, what they're moving back to is a Whipple. So a Whipple is an easy way to say this pancreatic duodenectomy. So what they're doing is they're taking out, as you can see in this picture, they're taking out some of the duodenum. The duodenum is gone, I should say, not some. They're taking out the duodenum, and they're taking out some of the pancreas is what I should have said. So duodenum is gone and part of the pancreas is gone. And so that's a Whipple procedure. It's a horribly long procedure. Surgery time is 4 to 6 hours just once they get in to do this procedure. It doesn't account for the opening and the closing of the patient. And so if you also notice, they also take off the gallbladder if it's not out already, and then they connect the common bile duct to the liver. So this is just a visual. However, they used to do these a long time ago. They went away, and they're coming back now. So it is a surgical procedure to help the patient remove that cancer, but they got to make sure that where the cancer is located, or the tumor is located on the pancreas, that it is the part that they can remove and they get it all. But we can't live without a pancreas as a whole. So it's a judgment call on the surgeon and where is it located, is the long and short of the story. Okay? But chemotherapy, and then of course limited radiation. Questions about any of that?